So welcome to everyone who is joining us for the first time, and welcome to our regulars that have been with us along this journey. So today, as you can see here on the slide, we are at meeting 4 of our person-centered care stakeholder consultation series. And the focus of the session today is on what are the core elements and mechanisms of person-centered care within the HIV response. And it's kind of a big question. So we are breaking it down a little bit, and you'll see that when we get to the breakout group discussion. So let me get to the next slide here. So here, as usual, we have a Jamboard prepared. We have a little QR code there for you if that's helpful. We'll also be sharing the links in the chat. So we do ask people to jump into the Jamboard. There you'll find a quick a slide basically for each of the presenters sessions today. So let me just quickly jump into the Jamboard and show you how that looks. So we have 9 slides, and if you just use these little arrows, you can navigate between them. So you can see the presenters today, and you can see each of the discussion questions that we'll be working to. So please just jump in here as you're listening to the presentations. You can use the little post-it note down here and just create a few notes here, and you can basically, participate in the discussion in this manner. We will be sharing you the slides. So it's just really more your thoughts, what resonates with you, what questions you have for the presenters. If you've got any technical issues at any time, please notify us in the chat. And so then we'll be moving to the breakout groups at the end, where you'll all have a chance to speak. So what are the objectives of this series overall is being to provide a platform for exchange on the concept of person-centered care, and to develop a joint consensus statement, which we'll be working towards in the fall. So you can see where we've got to. We're here in June discussing the core elements and mechanisms, but where have we come from? So this series actually kicked off at the AIDS 2022 conference in Montreal, in Canada last July. And that session was an in-person session focused on setting the scene of where we were trying to head on this journey. And really the discussion there centered around the importance of acknowledging contexts, identity, and complex clinical needs, as well as having healthcare provision more and informed by client experiences and specific needs. And that services that are community-led and community-based are essential, and peer navigators play an important role in that. And so we discussed at that meeting the key enablers really that we need to work towards are funding, targets, and policies, and access to the technology. And in meeting 2, we took a deep dive into the evidence around person-centered care, particularly around the evidence for person-centered care within the HIV response, but also a little broader than that, looking at integrated services as well. So we learned from that a number of person-centered care frameworks exist, and that the evidence within the HIV response itself is building, but that one size does not fit all, and that the level of integration of services can expand over time. It doesn't need to be all-inclusive from day one. We also learned, and that was reinforced again in May, that the investment in healthcare providers is key to this success, and that the long-term success of the HIV response and the health and reaching the quality of life of people living with HIV requires a focus on the changing needs over the life course. And that includes, of course, breaking down barriers to stigma and discrimination. So in May, just last month, we focused on service delivery considerations. And there we learned and discussed the importance of client choice, and that really isn't just providing options, it's providing a mix of options. So it's a mix of options that people can choose from and potentially change their minds and choose different options over their life course, particularly access to re-entry points into the health system as they need. We learned about the history of DSD and the idea around DSD 2.0, seeing further integration of the healthcare system, and that DSD was really initially driven by client activism and is person-centered at its core. So we've seen again how important integration is needed at all levels of the healthcare system. So this includes the level of statutory bodies, organizations, professional partnerships and clinical interactions, and validation of the policy guidance for person-centered care is needed at all of these levels. So the thing that we spent some time discussing was also the need for increased training, incentives and investment in the healthcare workforce to enable this shift to happen. And to enable that, we need deliberate policies, monitoring and mentorship from government donors and implementers. So what now is today, I will dig into the agenda for today in a little bit, but post the session today, it's not the end of the stakeholder consultation series. We will have an in-person event at the conference, the International AIDS Society Conference for HIV Science, that will be held in Brisbane, Australia in July 2023. And that group will be it will be a workshop focused on the draft consensus statement for person-centered care within the HIV response. However, we have very much appreciated the interaction with all of you, and we know that only a handful of you will be able to attend the conference. So in the September to December time period, we'll be reaching out again to all of you with detailed surveys, draft statements for your review. So please know that this is not the end of the conversation with you all. So a quick reminder, I've included this. I think most people will have got this on email, but just a quick reminder of the objective of today. So it's really to review and prioritize the core elements and mechanisms of person-centered care and how that differs for different population groups, whilst ensuring that individual client needs remain at the centre. And so with that discussion question, we're going to divide the breakout groups into the 4 95s, the HIV prevention, HIV testing and linkage to care, HIV treatment and integrated healthcare needs, and then quality of life. And we want you to reflect on what you think the core elements and mechanisms are, but how that might differ for a specific context, and then what the opportunities are to implement that even within current resource constraints. So I'm going to hand over now shortly to Marlene, who will be our moderator today. This is the order of events. We have 4 presentations followed by potentially some time for Q&A, or we may jump straight into the breakout groups if we run out of time. So I'm very pleased to introduce Marlene, who's the director of the HIV programs and advocacy team here at the International AIDS Society. She's also the executive editor of the Journal of the International AIDS Society. And she has been working in public health, research and management for over 12 years. So over to you, Marlene.
Thank you, Emma, and welcome to everybody. We have already 50 people in the room and more joining, so that's very exciting to have you all for this very important 4th session. And as Emma was saying, there will be plenty of occasion to interact and to provide us with your thoughts, comments, and feedback later on. But also today, we really hope that we're going to have a very interactive section and discussion. So please don't be shy during the breakout rooms. We really value your input and feedback. So I'm already prepping you a little bit for the second part of this meeting. But let's start with a series of presentations. So the first presentation that you are going to hear is from Rodney Olete. And Rodney Olete is a Filipino registered nurse currently pursuing a PhD in public health at National Cheng Kung University in Taiwan, and a nursing clinical instructor in the Philippines. As the technical consultant of Gabesa Pulang Lasso, is spearheaded the development of a supportive expressive group therapy based psycho-socioeconomic intervention for people living with HIV experiencing homelessness in the Philippines. He was also the lead researcher of a nationwide survey exploring chemsex among Filipino men who have sex with men in collaboration with the UNODC Philippines. Let's hear what he has to say. Thank you.
Hi, everyone. Welcome to the third meeting of the IAS Person Centered Care. My name is Rod, and I'm sharing this advocacy brief developed by International AIDS Society, exploring the intersections between HIV and homelessness, as well as the social determinants of physical and mental health and layered identities. Now, vulnerabilities leading to and stemming from the lived experiences of homelessness and HIV are explored in this advocacy brief. This also highlights models of good practices, and it culminates with a set of recommendations for stakeholders. This is designed to encourage global and policymakers, program implementers, and advocates to meaningfully engage individuals who have firsthand experiences of homelessness and to commit to adopting person centered approaches that integrate housing, HIV, and other related services into policy and practice. Experts by experience should be involved in all stages of this process, from policy formation to strategic implementation and throughout continuous impact assessment. Now, we all know that without a home, people are vulnerable, isolated, and marginalized. Evidence from multiple countries and different contexts suggests that people experiencing homelessness also experience higher burden of HIV, tuberculosis, mental illness, substance use, and physical and sexual violence compared to individuals with stable housing. Homelessness is a predictor of poor health outcomes. Morbidity and mortality rates from a wide range of causes are significantly higher among people without secure homes. Now, homelessness consists of a complex set of interrelated issues, reflecting inequities in our society. Many driving forces that contribute to homelessness also contribute to vulnerabilities of HIV acquisition and poor HIV outcomes. Homelessness also magnifies other vulnerabilities to social injustices linked to HIV. These factors, in turn, reinforce each other to further exclude people from access to social services, including housing, employment, and health. Now, in the Philippines, we have conducted a needs assessment survey during the pandemic, and I strongly believe that the outcome of our data collection strongly supports the concept of intersectionality between homelessness, unemployment, HIV, and mental health. Now, this research study was published in the Asia Pacific AIDS and Co-infection Conference back in 2020, and the research found that many people living with HIV reported a decrease in their monthly income. And there was also a significant proportion who claimed to have lost their jobs. And as a result, it led to residential displacement and homelessness and developed depression and related symptoms. Now, we have also evaluated the relationship between job loss and mental health, and we found that people living with HIV who lost their jobs due to the pandemic were more likely to experience anxiety related symptoms. Depression related symptoms, on the other hand, were associated with job loss specifically for the younger demographics of 18 to 35 years old, particularly living in the dense communities of Metro Manila. Now, this is just one of the many evidences that inspires the development of a comprehensive and person centered care intervention, specifically to address homelessness. Now, IAS advocates for 8 elements, including housing and social determinants. This means that immediate provision of stable housing and reduced engagement with criminal justice system combined with the provision of occupational therapy, education, employment and life skills, especially schemes in providing individual placement opportunities. Second element of a person-centered care intervention are pharmacologic interventions, such as inclusive treatment for HIV, tuberculosis, hepatitis C, opioid use, and mental health challenges. We also need to include psychosocial interventions that should be based on a multimodal approach, including contingency management for people who use stimulants, including motivational interviewing, cognitive behavioral therapy, mindfulness, and peer support. Then there's also the importance of case management in order to provide enhanced coordination and delivery of health and social services with the help of our peer navigators and peer leaders at the front line of the community. Now, we also have to promote well-being meaning that we should provide access to exercise, healthy activities of daily living, and even exposure to nature. Then we have disease prevention, including access to prevention and screening services, including harm reduction, vaccination, overdose prevention, and targeted and integrated screening for HIV, hepatitis C, tuberculosis, and even other sexually transmitted infections. Then, lastly, but definitely not the least, are tailored interventions for women and young people. For women, we should include on site pregnancy services with harm reduction services, parenting skills, and integrated maternal and mental health services, together with community empowerment programs, especially for female sex workers. For the youth, we should consider the value of safe environment and caring relationships, as well as the potential for family-based therapy, cognitive behavioral therapy, and brief interventions for young people, especially those who are engaged in drug use. Now, these are just the overview of the advocacy brief that IAS has published recently. So we strongly encourage everyone to take a moment to download it if you haven't yet. And if you haven't yet, you can get it from this QR code. You can scan it in front of your screen, and later I will be sharing the website as well. And I'm so eager to exchange discussion with everyone in terms of your insights about the recommendations that were included in the advocacy brief. So take time to read through the recommendations, and let's talk more about it later on. So that's it for me. And once again, my name is Rod Olete from the Philippines, and thank you so much for listening. See you later.
Thanks so much, Rod. Our next speaker is Dr. Lisa Sterman. And Dr. Lisa Sterman began her career in HIV as a volunteer on San Francisco General Hospital's infamous AIDS unit, Ward 5A, in 1987. She has worked in private practice as an HIV specialist and internist and teaching faculty in San Francisco for 24 years, also doing extensive HIV phase 2 to 4 clinical research and HIV consulting during that time. Lisa also served on the board of directors for the San Francisco AIDS Foundation for 7 years and currently serves on the organization's community boards of directors. Dr. Sterman joined Gilead Sciences in 2021 as Global Executive Director on HIV Prevention for Medical Affairs. Lisa, the floor is yours now.
So I definitely want to start by saying that I feel like the most important connection for person-centered care is that between the provider and the person in front of them, whether they're HIV positive or someone who could benefit from PrEP. So we're going to talk a little bit about status neutral testing and how to augment that provider relationship with the person who has HIV or who may benefit from HIV prevention services. Next slide, please. And as we move toward the UN 95-95-95 goals for 2025 and 2030, we continue to recognize that global challenges of integrated person-centered care are necessary for many people to live longer, healthier lives with HIV. Many local and national organizations and governing bodies are increasingly focused on the fourth goal, which is good health-related quality of life. This goal requires investment in healthcare systems, expansion and coordination of services, and caring and compassionate providers to create healthy and equal and equality across all things and address stigma, reduce discrimination on all levels. Next slide, please. Thank you. So successful relationships between providers and people with HIV or those who would benefit from PrEP are dependent on many factors. Normalizing health-related conversations, utilizing information about sex, sexuality, as well as access to affirming care that is sensitive to culture, practices, gender identity, geography, among other factors. This will allow us to create an environment that will minimize medical mistrust and build strong, lasting relationships between patients and providers. Next slide, please. Oh, it's a build, sorry. One place to start with this is a status neutral encounter model for HIV testing. And this assumes that everyone could benefit from connection to care and services. So those testing positive for HIV can be more rapidly and actively linked and re-engaged in care. Those who test negative can be offered comprehensive sexual services, ongoing screenings, STI testing, and discussion of HIV prevention options. Next slide, please. In many cases, people are living longer, healthier lives with HIV. One international expert panel of both providers and people living with HIV recently suggested 5 key pillars for long-term success. The first is sustained undetectable viral load. This is achieving undetectable viral load, which will support good health, as well as HIV prevention through U equals U. The second is minimal impact of treatment and clinical monitoring. So with newer ARVs and fewer drug-drug interactions and innovative mechanisms, we can allow many people to reduce the number of healthcare visits and the monitoring tests necessary for success. The third is optimized health-related quality of life. Support for long-term healthy aging, increased empowerment for people living with HIV to become more engaged in their healthcare journey is critical for both mental and physical good health. The next one is lifelong integration of healthcare. And healthcare providers and the relationships they have with people living with HIV should be multidisciplinary, integrated, and culturally sensitive, and should help empower people to make informed choices about their own care. The last is freedom from stigma and discrimination. I feel like this is mostly the most important one. And this is really necessary across all healthcare settings. We need to have judgment-free support from providers, peers, society, public health campaigns, educational opportunities in the community. And only if we create all of these things and help support them are we going to help remove the structural and punitive healthcare policies. Next slide, please. So what are the management goals now? I mean, they've really changed. So what's the difference from earlier years in HIV? I mean, really in the beginning, the key was to keep people alive, to find something they could tolerate, to help them understand the complications of HIV as they, hopefully did well and didn't have life-threatening side effects or intolerabilities. And now we've really moved to a new era where many regimens are very tolerable, and it's important to really focus on living long, healthy lives and focus on things like smoking and drinking and other abusive to the body activities that could cause cancer, because it's much more likely now that people will live long enough to have to be concerned about these things. Next slide, please. There are many factors that need to be considered in conversations between people who would benefit from PrEP and providers. PrEP is a whole different thing. People who are receiving PrEP aren't ill. They aren't patients. They're people who want to prevent a disease. So this is equally important to understand each individual's unique situation and create non-judgmental and supportive care environment so that you can build trust in a person-centered way. This is another kind of relationship, and oftentimes, people who providers who provide HIV care are also providing prevention care, but we need to expand the ability to provide prevention care to all forms of healthcare and other ways to engage people in prevention activities. Next slide, please. I think that's a build slide. You can build it all the way out. Thank you. When it comes to tailoring HIV prevention efforts, there are both biomedical interventions, including medications with different mechanisms of action. There's new innovative technology coming along for prevention. As well, there are implementation strategies and people's chosen behaviors, which will all support HIV prevention efforts. Both communities as well as individual providers, healthcare systems, and governments also play a role in creating or eliminating barriers to prevention. Critical factors involve engaging individuals, communities, providers, and healthcare systems in order to overcome medical mistrust, stigma, and access challenges to healthcare. PrEP is more than just medication. It requires an individualized approach to care. Next slide, please. So COVID's taught us a number of different things. This data from a satellite session in 2021 at the Research for Prevention meeting shows us that COVID has changed many aspects of HIV treatment and prevention efforts in healthcare and delivery systems worldwide. Some simplifying care pathways. Many creative new healthcare delivery models evolved during COVID and are helping to demedicalize elements of HIV prevention by offering options for telehealth, use of nurses and pharmacists in care delivery, new online care and delivery platforms linked to awareness through things like chatbots, social media, and other creative mechanisms. Mobile clinics have expanded, bringing care into the community. These and other innovative strategies have had lasting effects on care delivery, furthering the goals of simplification and demedicalization for people who would benefit from prevention efforts. Next slide, please. And we have an ongoing commitment to innovation in HIV, both in social and biomedical approaches. This innovation helps to support shifts in healthcare systems and systems delivery and services. Innovation also broadens access to care, as in telehealth or all other alternative care delivery settings, and can work to reduce stigma and discrimination, supporting hard-to-reach populations and bringing them into care with more choices and service delivery options. Next slide, please. Current research and clinical trials are also evolving to be more person-centered. Everyone benefits when we all have a seat at the table. Development of criteria for research site selection, where staff and investigators are representative of populations and communities that they serve, builds trust and inclusion. Healthcare practices such as supporting and studying gender-affirming care for people of trans experience alongside clinical trials supports inclusion of trans and gender non-binary communities. Development of long-acting formulations to address stigma, healthcare access, and increase trial participation of historically underrepresented people empowers inclusion of multiple diverse communities. Last slide, please. To conclude, the foundations of person-centered HIV care and prevention are built from the ground up. Social, community-based, and policy-based changes will help address stigma and structural factors. Supportive global practices that focus on the engagement and retention of individuals in culturally competent care allow every provider and person with HIV or people who would benefit from prevention the opportunity to build a trusting and empowered relationship together, and will help end this epidemic for everyone, everywhere. Thank you very much.
Thank you so much, Lisa. Our next speaker is Keith Mayonnaise. Keith Mayonnaise is the technical advisor for community responses and systems and focal point for 6 high-impact Africa portfolios in West and Central Africa for the Global Fund to fight AIDS, tuberculosis, and malaria. Keith leads the fund's work and strategic investment in community-led monitoring for HIV, TB, and malaria.
Good afternoon. Thank you so much for the invitation to discuss community-led monitoring and the links to people-centered care. I'd like to start with what does people-centered care mean to the Global Fund? The Global Fund's new ambitious strategy responds to the challenges by getting back on track against HIV, TB, and malaria, contribute to the SDGs, and achieving universal health care. Against HIV, this means closing the HIV prevention and treatment coverage gaps through equitable service delivery models that are tailored to people's needs. Against TB, tackling persistent vulnerabilities, barriers, and gaps that limit access to quality TB programs. And against malaria, people-centered integrated interventions that align to the context of individual communities while addressing barriers to equitable access, improving quality of services. This, of course, includes accelerating the shift from siloed interventions to more integrated, people-centered models of care, meeting holistic health needs of people. In the strategy framework, people-centeredness is critical reinforcing objective to ending AIDS, TB, and malaria. As the Global Fund, we call it integrated people-centered quality services are not only delivered around a disease, but organized in a way that considers individuals' health needs holistically and places people and communities at the center of services. Of course, this requires supporting and incentivizing HIV, TB, malaria service integration, where it's relevant, together with services to address co-infections and comorbidities of the three diseases, other adjacent health areas such as SRHR and reproductive, maternal, newborn, child, and adolescent health services, relevant COVID services, and integration into primary healthcare. So now I'm here today to talk about community-led monitoring. How does community-led monitoring as an approach contribute to more people-centered care? So first, maybe let me start by saying community-led monitoring, or as everybody calls it, CLM, is an independent accountability mechanism that are designed, led, and implemented by local community organizations working closely with recipients of care and key and vulnerable populations. Through community-led monitoring, these clients and recipients of care and other local community members use structured data collection and analysis methods to produce evidence-based recommendations for improved accessibility, acceptability, affordability, and quality of health programs and services. This is also known as the AAAQ framework. So what does this mean in practice? Well, first of all, as communities receive health and legal literacy and other empowerment interventions, clients of service access collect and analyze quantitative and qualitative data on predefined selected indicators. These indicators are determined by communities themselves and often linked to problem statements, whether it is quality of services, whether it is social and structural issues affecting uptake of services, or the accessibility of services. This feedback then, if done recurrently, routinely, with co-problem solving approaches, provides constructive feedback to the service providers. And this includes public health facilities, of course, program managers, ministries of health. Through this process, you can think of it as a spanner. There's an opportunity to adjust how programs are delivered. Communities then, together with the service providers, find solutions in real time and strengthen the local, regional, or national response by being focused on clients' needs. Through this, you can land on better health outcomes around that AAAQ framework that I spoke about earlier. CLM, like I have seen, can lead to real impact. I've seen significant improvements across the world from small scale to national CLM approaches. This includes increase in service uptake, appropriateness of services for women, key populations, and also provides a legitimate source of strategic information from the client's perspectives for the introduction of further integration and differentiation in terms of services that then meets people's needs. Throughout the last two cycles, the Global Fund has invested significantly in community-led monitoring, of course, within the three diseases and for particular communities, but also very excitingly, for example, in the DRC, the Global Fund is currently supporting an integrated CLM approach that includes HIV, TB, SRH, WASH, COVID, and malaria. Just some results from how community-led monitoring has resulted in improved health outcomes and improved service delivery. In 2016-19, the Global Fund invested in a regional community treatment observatory that was implemented by 11 PLHIV networks in West and Central Africa. The frequency during the first year of implementation and data collection of recorded ART stockouts reduced by at least 10% over a one-year period. And this is just one example of how community feedback has resulted in finding solutions to issues that clients face in terms of accessing essential and continued quality services. In Malawi, community-led monitoring implemented through Manaso has led to the construction of new ART clinics within a specific area where communities have noted that the current ART access point is inaccessible and unaffordable to reach. It's also trained female nurses when the need was identified for cervical cancer screening to be provided in addition to HIV services, particularly for women. In Uganda, PLHIV have become expert clients to offer interpersonal counseling and information sharing in a couple of pilot districts. What this has resulted in through engagement and routine engagement with key populations themselves was the identification for the need of another drop-in center. This has, of course, resulted in more people being able to access particular KP services or KP integrated services, and also has led to the introduction of a specific day clinic for people who inject drugs. I thank you for this opportunity, and please do reach out if you have any follow-up questions. Apologies that I'm unable to attend this webinar in person. Thank you.
Brent has held numerous peer support and management roles in the Australian HIV sector across a range of programs, initiatives, and research partnerships focused on people living with HIV, including those who are recently diagnosed, people who inject drugs, and gay men and other men who have sex with men living with HIV. Our second speaker will be Benjamin Riley, and Benjamin is the Policy and Public Affairs Manager at ASHM, leading the organization's policy and advocacy work relating to HIV, viral hepatitis, and sexual health in Australia. Benjamin has worked across research, clinical, and community organizations with a focus on advocating for LGBTIQ communities and for the needs of people living with and affected by blood-borne viruses. He's also a widely published freelance journalist. And our final speaker will be Lucy Stackpool-Moore. Lucy is WATIPA's founder and managing director and a recognized authority in global health in relation to diversity, inclusion, and reducing stigma. In 2022, she facilitated a series of consultation for NAPWHA and ASHM on person-centered care and HIV treatment initiations. And she's supporting currently the finalization of a national STI strategy for Australia. So let's hear from those three speakers.
Before we begin this session, I'd like to start with an acknowledgement of country on behalf of ASHM, NAPWA and WATIPA. I'd like to acknowledge elders past and present and pay my respects to all Indigenous colleagues joining the session here today. Myself, Brent and Ben are all joining from Gadigal land in the Eora Nation here in Australia. Hello, and thank you very much for inviting us to present the Person-Centred Care Consensus Statement from Australia. We're really happy to be here today and extremely proud of what we've been able to do so far in Australia. I'm going to say a little bit more about what it is and where it's come from, and then hand over to colleagues to explain a little bit more about the community and clinical perspective on this as well. So why did we want to do it in Australia? Well, we wanted to really look and define the who is at the centre of person-centred care and make sure it is inclusive, reflecting diversity, covering things like intersectional identities and really reflecting the heterogeneity within groups around different health needs and also how they may change over time. And we also really wanted to look at who is providing the care to ensure that it is person-centred. And again, this notion of diversity is critical here, whether it's care provided from clinicians, specialists, nurses, peers, allied health professionals, etc. But it's really quite a diverse set of people also who are the caregivers in terms of person-centred care. And something I'd really love you to listen out for across all of this that we're really proud of in Australia is the focus on autonomy and agency through all of this. So without further ado, I'd like to read you the statement we've come to, and then I'll say a little bit more about it afterwards. So the statement reads, clinicians, community, government and industry delegates agree that person-centred principles should guide the delivery of HIV-related care to ensure the highest attainable standard of health for people living with HIV and people at risk of HIV acquisition. Person-centred approaches centre a person's autonomy, dignity and rights, respect a person's decisions and experiences, support a person to lead the dialogue about their health, build relationships grounded in understanding and trust. These are holistic approaches that centre people and their goals beyond a narrow focus on disease control, prevention and viral suppression. Person-centered care is about people having the space to articulate their priorities and working cooperatively with healthcare providers to make decisions that work for them. Ultimately, a person is an expert on their own needs. Healthcare providers and policymakers can best help people living with HIV and people at risk of HIV acquisition by centering their concerns, desires, and experiences. Respecting people's autonomy empowers them to take control of their health and promotes good quality of life and instills hope. So just quickly, why now and why in Australia? Well, we're really responding to some awesome work led by Jeff Lazarus and colleagues globally for a consensus statement on the role of health systems in advancing the long-term well-being of people living with HIV that was published in Nature Communications in 2021. And closer to home, some fascinating work from Brent Allen, Crawford, Graham Brown, and Aaron Kogel and others titled Client-Led Care in HIV, Perspectives from Community and Practice. That was also some work published in 2021. So it's very timely here, and you'll hear a bit more from Brent in a moment about why it's so exciting in the Australian context. So finally, just in terms of how we did it and the sort of who was at the table, it was multidisciplinary and multi-stakeholder in terms of the engagement and the discussions. We had a workshop with clinicians, community, government and industry representatives, and a very in-depth discussion facilitated around some very focused topics, a draft statement prepared with opportunities for input and general agreement pretty much at the end of the day, but then some wordsmithing after the fact to get to where we are with the statement. Just in conclusion, there's 5 really critical priorities that have been identified from this process for person-centered care in Australia. The first one is the shift from disease control model of care to one focusing on well-being of the individual seeking care. The second one is a shift away from strict biomedical understanding of HIV and comorbidities to one which captures psychosocial and structural determinants of health and incorporates quality of life. The third one is to ensure a holistic rights-based approach that centres people's autonomy. It's the autonomy back again. Fourth one is to build systems that integrate peer support workers into care models and service delivery. And the fifth and final core principle is to enable and listen to people living with HIV and lead the dialogue about their health. So I'd like to hand over now to Brent Clifton from NAPWA, who's going to say a little bit more about priorities for the community. Brent, over to you.
Thank you, Lucy, and echoing the thanks for letting us take part in this really important work. So I'm going to talk for the next 3 to 4 minutes with a community perspective on person-centered care, in particular the Australian context, and talk a bit about how community were engaged with this process and some of the work that kind of has led us to this point. And also you know, what we brought to the table at the round table to help inform the statement that you've just heard. I think it's important for me to emphasise at this point that when we're talking about person-centred care in the Australian context, it really has its genesis in quality of life and improving quality of life or health-related quality of life for people living with HIV. So in Australia, numerous studies have found that people report a very high satisfaction with treatment, but experience a lower overall well-being. So these data have prompted the community sector in this country to interrogate why this is. So our starting point is that we know the partnership between a person with HIV and their doctors is vital. And over the years in Australia, health systems have improved their abilities to identify, diagnose, treat, and increasingly achieve viral suppression among people living with HIV. Despite these advances, a higher burden of multimorbidity and social inequities appear to be the primary drivers of poor health-related quality of life in comparison to the communities of people in Australia without HIV. And this is all further exacerbated by stigma and discrimination. So with this as our context, HIV positive people in Australia and NAPWA started to look at best models of care that can complement conventional HIV care strategies and enable empowerment and greater engagement with care, potentially improving the care continuum and overall quality of life for people with HIV and for those who can and want to lead their own care. And it's hence how we found ourselves engaging with the consensus statement and the roundtable. So as I've mentioned, our starting point with person-centered care is always about improving the quality of life of people living with HIV. My organisation, NAPWA, has previously undertaken a series of web-based community engagement events to build our understanding of how people in Australia define what a good quality of life is. The result of this is published on our website under the Australian Community Accord on Quality of Life for People with HIV, which is both a commitment and call to action for the partners within the HIV response within Australia. Put simply, the Accord defines a framework based on analysis of our extensive community consultation and identifies both positive and negative drivers of what quality of life of what positive people perceive to enhance or not in their quality of life. An example of positive drivers include meaning, belonging, care and support. And on the other side of the coin, negative drivers include isolation, stigma, distress, and insecurity. So it's with this kind of understanding that we have high treatment satisfaction, yet we want to improve the quality of life of people with HIV in Australia, that we brought our recommendations and engagement to the roundtable. It was important for us to emphasise that social aspects of HIV deserve equal attention as do the clinical aspects. But also we wanted to demonstrate our skill and knowledge of HIV and demonstrate how peer navigation can drive can help drive person-centered care in Australia. So people with HIV understand that health systems can be stretched and that clinicians may have competing priorities and limited time at their disposal. Similarly, the cost of accessing healthcare for anyone with chronic health condition can add up and become a barrier for people accessing care or engaging or leading their own care. So for us, promoting collaboration between clinicians and community organisations who offer peer navigation is a critical way forward to improve the quality of life in Australia and help drive better person-centred care within our settings. And I guess there are four main kind of pillars that we kind of look at peer navigation, supporting the work that is done within clinics that are a benefit to the response, and they are the value of the individual circumstance, putting that person and all of their life needs into the picture, and promoting social connection, which we also know is a positive driver of a good quality of life. It goes further by supporting the clinical workforce, particularly where the processes and referral pathways are already ingrained. And it's also potentially more cost effective. The Australian healthcare budget is one which kind of goes up and up and up, and finding ways that we can save money and work with community to deliver care and services for people with HIV can only be a benefit to the whole healthcare system. So that's where we came to with the roundtable preparation. I'll now hand over to my colleague Ben Riley from ASHM to talk from the clinical perspective.
Thanks so much, Brent and Lucy, and thank you to the IAS. It's really great to have an opportunity to talk about this, the work that we're doing. I'll talk a bit now about how we engage clinicians in the consensus making process. So, of course, best practice models of person-centered care center the needs of the person living with HIV, but we also recognize that clinicians and other healthcare workers have a responsibility to enable that care. So engaging clinicians in the roundtable and in the consensus making process was important, not just so that they could provide input, but to ensure that clinicians can better understand the priorities of people living with HIV. For my organization, ASHM, we provide education and support for the HIV clinical workforce. Person-centered care is a principle that we do aim to embed across all of our work. So we do that by ensuring clinicians are aware of and, where possible, effectively engaging with peer-led models of care. So that's one priority in our clinical education. In Australia, this work is supported by national policy frameworks, which is great. Person-centered care is embedded as a guiding principle in our national HIV strategy, and we're in a continuing process of further integrating that principle across these strategies, actions, and implementation. So one model of care that's more commonplace in Australia is the use of peer navigators who are situated alongside general practitioners. Some Australian research looking at GP perspectives on peer navigators found that while GPs do value the role of peer navigators, a challenge for person-centered models of care is building effective referral pathways between GPs and peer navigators. We do see instances where it works really well, and there were some case studies presented at the roundtable that demonstrated that. But where that happens, it often relies on existing relationships with individual clinicians rather than being embedded in health systems. And this was a theme that emerged in the roundtable. A focus for the clinicians engaged in the process was the need to find practical ways to address barriers to person-centered care within healthcare systems. Those barriers, as Brent's already spoken to a little bit, include limited time and funding constraints. So another priority for clinicians at the roundtable, as Lucy's mentioned, was the autonomy of the person living with HIV engaging in care, and in particular, understanding that that person's priorities may not always be the same as the priorities of the clinician. For example, factors such as economic and housing precarity, employment insecurity, multimorbidity, social isolation, and stigma may be just more pressing for a person living with HIV than engaging in treatment, and that needs to be understood by clinicians. So as such, supporting person-centered care requires clinicians to have that broader understanding, which could be supported by, for example, as I've mentioned, embedding peer navigators within care teams. So this consensus building process has been really important for ensuring that clinicians and communities have a shared understanding of what it means to implement person-centered care. I'll hand back to Brent.
Thanks, Ben. And I'm tasked with the job of wrapping up this recording for our group. So the question that I'm going to pose to myself and then answer is, what will the consensus statement now be used for? And what opportunities does this have into the future? Recently in our national strategies, person-centered care has been singled out as one of the key principles to help end HIV transmissions and support good quality of life for people living with HIV. This consensus statement provides us with an opportunity to continue these efforts and more clearly define what person-centered care means in the context of Australia. We're very lucky in this country to have high rates of testing, diagnosis, retention in care, treatment, start, and viral suppression, the care continuum. However, improvements in quality of life are still needed. And this person-centered care consensus statement hopefully can be used as a vessel by which the Australian HIV community response can further collaborate and partner with its North Star goal of achieving good quality of life for people living with HIV. Similarly, despite our successes with the care continuum, there are still parts when you start to break down by subpopulations, some inequities which start to appear for people who are from more socioeconomically diverse backgrounds, culturally diverse backgrounds, who may not enjoy the same quality of life outcomes as people who have traditionally carried the epidemic in Australia. So gay men, for example, Australian-born gay men. So the consensus statement hopefully gives us a tool by which to start understanding and addressing some of those inequities and going to build programs and supports that do achieve good quality of life and good health for all people living with HIV in Australia, and have a world-class healthcare system that works even better for us than it already does. That's where I'll finish it up. We want to, on behalf of Lucy and Ben, thank you so much for the opportunity to present this work. We've really enjoyed taking part in both these workshops in the past, but also this whole process of engaging with person-centered care. And we look forward to seeing some of you in Brisbane. Thank you.
Thank you, and thanks to all our speakers. We are a bit already delayed, but we have few minutes to ask questions to the speakers who are in person with us today. So if Rodney and Lisa could come on camera, and let's see if we have some question from the audience for them. Here we go. I see both of you. So I see that in the Jamboard, no one has put question yet. Let me see in the chat if there's any question, or in the meantime, if you, Rodney, have a question for Lisa, or Lisa have a question for Rodney while we're looking at the chat, please feel free to go.
I have a comment.
Go ahead, Jules.
Yeah, so this is Jules Levin, New York City. I've been focusing on aging and HIV for 17 years. I've led policy and education for 17 years. And in the United States, things have changed a little bit. I don't see that happening outside the US very much, although there are a few aging HIV clinics in Western Europe. The whole discussion today around person-centered care is great, but I didn't hear one word about patient or person-centered care for the elderly or older population from any of the speakers, only sort of general for people with HIV, which I found a little disappointing and concerning. So
I can make a comment about that.
And just one more thing. In my own experience, and I speak to a lot of people here in the United States and Western Europe, patients, policy people, doctors, government officials, quality of life is something that people in their 40s and 50s say is important to them. But once they hit 70 and start having physical and mental disabilities, then quality of life is not as important as the fact that they're not getting good care and that they're really suffering with disabilities. And these are people with HIV. So that's when quality of life doesn't matter as much as real care and comorbidities.
Right, your point is really well taken, Jules. This is Lisa. Sorry, I have a little hoarse voice today. Thank you for that. I think what I've seen, since leaving practice and joining a global team is that the focus on research and inclusion of people. Remember, all of our trials used to stop around 60, 65, but now I feel like we're really starting to focus in with research and inclusion in many of our trials and many of our external engagements and education on this age group, because we recognize how many people are aging and aging well with HIV. But there is this big discrepancy. Some people have fewer complications than others. And I agree, there should be a whole new specialty in medicine for geriatric HIV care. It's part of our communities. It's something we need to focus back in and figure out what are the unique needs of those communities. And I feel like there is some work in that area and awareness in that area, because as you see, many of the clinicians, like myself, are now reaching those decades, and we recognize what it's going to be like to take care of and to support the people who are getting older. And it's care intensive, and that supporting from lots of different angles, from government angles, from payers who really don't understand what's happening. All of those things need to be addressed. I totally agree. And there are people working on it.
No, listen, I've been working on it. I work with the NIH. I work with HRSA. The reason HRSA opened up 10 aging clinics is because of me. Here in New York State, we opened up 13 aging clinics because of me. So I'm fully aware. And I think Gilead does a lot of good in terms of providing funding for lots of efforts, including this. But really, I was looking for a response from all the others who talked today, besides just Gilead, who talked about the patient population. None of them really talked about the elderly population and their needs.
Rod, would you like to add anything from the Philippines perspective and your experience?
Hello, everyone. From the Philippines, we have already an existing organization that handles aging and HIV, and then they're just starting. They started a year ago, and then slowly doing their job as well in pushing for and advocating for the rights of the aging population of people living with HIV. But to be straightforward about it, we're still far from it, but we're doing our best to keep up.
Thanks, Rod. Just being very mindful of the time, we'd love to move to the next part, which is breaking into small group to discuss. And you remember that the goal is to develop a consensus. So you will have a Google Jamboard link in the chat. We will split you in 4 different groups. And in each of the groups, we are going to discuss what are the core elements and mechanisms of person-centered care for people living with or affected by HIV related to either HIV prevention, HIV testing and linkage to care, HIV treatment and integrated healthcare needs and quality of life. So 4 different questions and 4 different groups. And what we would like to have is a conversation about how does this differ when considering the specific context of individuals from different population groups. And I think that, Jules, this is very relevant here because we're talking about different individuals at different stages of their lives. And we would like also you to think a little bit about the opportunities to implement person-centered care, even within current resource constraints. So the team will now split us in 4 groups. Please do go on the Jamboards. And we will resume and see each other in a bit. Everybody, we are back in the main room. So we are close to the end. But what I would like to do is ask each of the groups to report back on the conversation you had. So you remember that there were 4 main themes that we wanted to discuss, and I'm going to call my group actually, for what was looking at the core elements and mechanisms of PCC for people living with or affected by HIV related to HIV prevention. And I'm not the rapporteur, Natalie is. So Natalie, over to you.
Sure, thank you. We talked about we talked quite a bit about stigma and in the HIV prevention space, and we talked also a little bit about HIV treatment, but stigma among HIV disclosure for general practitioners and the transition into the HIV treatment space. We talked about, we talked a lot about, thank you for putting that up on the screen. Wisdom shared with us the example from Nigeria right before we transitioned to talk a little bit more about what their model was, and really having this community-led approach and a one-stop shop clinic, so that a place for individuals to go where it's not solely for HIV treatment, but broader services and sort of meeting clients' needs in one place, because we talked a bit about sort of the stigma around HIV treatment being in standalone places, and that contributing to some of the stigma and individuals in other localities and contexts not wanting to be outed or in spaces where it was solely for HIV treatment. So I think that talked a lot about, trying to sort of summarize what we talked about in a short amount of time, but hopefully that the Jamboard also reflects that conversation.
Thanks a lot, Natalie. For the testing and linkage to care, Rodney, are you the rapporteur, or is it someone else in your group?
Yeah, I can summarize it, if it's okay. Can we move to the next slide? Thanks. All right, so we have made like 7 major points, and for the first half on testing, on one participant mentioned that clinicians need to emphasize on the hope or the treatment or all the other, the main idea is not to basically give up on life after HIV diagnosis, and it should be emphasized by clinicians during the pre-counseling or the pre-test counseling. Testing should also be widened in terms of its modalities so that everybody has the options, such as self-testing and community-based testing, rather than heavily focused on facility-based testing. And then clinicians should also design the testing with the clients, and clients should always be part in the conversation involving HIV testing framework and modalities. Then we talk about testing and linkage there's the need to focus on disclosure too. The partners should be counseled about and be informed about the whole situation during testing, but it should be done carefully and ethically. Linkage to care brings services nearer to the people, meaning that there should be more healthcare facilities to be open all over, covering wider geographical locations. And healthcare providers should have a continuous professional growth and development in terms of the updates on HIV treatment, so that they would include this when they are linking the clients to care. And lastly, I also shared a little bit about one-stop shop model, wherein the healthcare facilities should be comprehensive enough in providing all possible health services, including non-biomedical services, in just one facility, so that the linkage to care, the time between the diagnosis and linkage to care, should be shortened, and that closes the gap, and that will prevent treatment fallout. I guess that is from all of us.
Thanks so much, Rod. The third group was focusing on treatment and integrated healthcare needs. And Lisa, I think you are the rapporteur for this one.
Yes, I would actually, if he's still on the line, there was this lovely graduate student who did a wonderful job describing his research, and it kind of summarized. Are you still on the line?
Yeah, I'm still here.
Okay, why don't you talk about what you were talking about with your research and summary? I thought that was brilliant.
Yeah, sure. So my name is Anish, and I'm a PhD candidate that works with migrants who live with HIV in high-income countries. And one of the things that we really were honing in on was this idea of competing priorities amongst migrant communities. So when a lot of these migrants come to, for example, Canada, we don't necessarily have a massive issue in terms of getting them screened, but more so with keeping them retained in the healthcare system. And a lot of that is because a lot of these people have challenges around housing security, financial security, making sure that they have jobs, because and these kind of issues need to be sorted out concurrent to their HIV related needs. Because a lot of these challenges, you know, when we think about the HIV of a person, we can't just take that away and remove that from the whole person. This holistic being has so many different competing needs that need to be concurrently addressed. And so that's kind of what we were talking about in our smaller discussion group.
Thanks a lot, Anish and Lisa and participants in that group. Fourth group was focusing on quality of life. And Lina, do you want to report on what has been discussed?
Yes, I'm going to try and summarize this really quickly. Basically, to respond to the first question about the core elements and mechanisms of person-centered care, we really focused on two things, which is improved screening for co-infections and comorbidities, and most importantly, and this is a point that's true for all age groups of people living with HIV, is improved educational opportunities. And really, to have empowered clients, we need people to know more about their own health. Jules was mentioning that a lot of older people living with HIV do not know what frailty is. They do not know what the different impairments are that you can have, and that this is related to HIV. So really the 2 points were improving screening and education of people living with HIV. And then we looked at the different specific groups and what kind of intervention would be important to bring up for them. We had mentioned harm reduction interventions that need to be improved. And so integrated services that address both co-infections and HIV. But also that services in general need cultural and language specific elements to them, so that they really speak to the people and to the individual, and that they are understood. We cannot kind of go into services and expect clients to be expert clients when they start their journey through lifelong art. And I'm gonna stop here. I know we talked about many more things.
Thanks a lot, Lina, and thanks to all the participants and those who stuck with us in those various breakout rooms. If there's something you would like to add that you've been thinking, because we had a short time and you're like, oh, actually I have a great example to share, please do not hesitate to contact the PCC team here at IS. And I'm going to leave the floor to Emma to wrap up this really, really great session. Again, a massive thank you to all our speakers. those who were present and those who could not, but pre-recorded and really wanted to be engaged today, and all of you for the great conversation and discussion we had. Emma, over to you.
Thanks, Marlene. Apologies to everyone for the technical difficulties earlier, and thank you so much for sticking with us. I think it's been a really good session again. As Marlene mentioned, please don't hesitate to reach out to us, and rest assured that we'll be in touch. Hopefully we'll see some of you in Brisbane, and the rest of you will be liaising with regularly in the fall. So thank you very much, and thanks for sticking with us today, and we'll speak, and for all your hard work. Thanks so much. Bye, everyone.
Thank everybody. Bye.